So today I'm going to be talking about how to properly insert in a nasogastric tube, and I'm also going to talk about the importance of enteral and parenteral, I can't say that word, nutrition, also some complications of both. So to get started, I'm going to have my lovely assistant here. I'm going to just demonstrate how to insert an NG tube. So first of all, before you even insert it, I'd gather my supplies, but all I have is this handy dandy shoestring. So you would get your nasogastric tube, a flush, and so you could check your aspirate. And then you'd also have some lube, or the stuff that you put on the end. And so then to get started, I would measure. Can you turn sideways for me, please? Thank you very much. You measure from tip of the nose to the pinna, and also down to the xiphoid process here. And you can turn back around the front. And to do that, I would probably just mark it so you can get an accurate depiction of where your nasogastric tube is and if it's displaced any, or if you haven't gone in far enough. So then after that, I would lube up the end, and I would have my lovely patient here lean her head back, and I would place it in her nose. And then once it gets down to her throat area, she'd kind of cough, and I'd push her head forward. You don't want to do a lot of pressure, but they are going to want to kind of jerk back, so you got to push it down. And you're going to tell them to swallow, like on water or something, to advance it down. You're just going to advance, advance, advance. And then once you get to that mark, you are going to secure it as much as you can. And then you're going to get aspirate and check for a pH, preferably less than 5, because that indicates that you're in the right place. And then you would get an x-ray placement to really confirm it, because that's the best way. So if you'd like to sit down. Okay. Now I'm going to take a seat. So I'm going to just explain like the description of the procedure, some indications, outcomes, evaluations, and things like that about it in NG tube insertion. So a nasogastric tube is just the flexible tube, my lovely shoestring, that will be inserted through the nostril, down the esophagus, and into the stomach. Placement will be confirmed by the x-ray post-procedure, as I said. A few indications for an NG tube is for like compression or decompression, if you need to remove the stomach contents or if you need to prevent any type of hemorrhage. Then also another one is lavage, which is like the washing of a stomach. But what we're really going to focus on today is like the nutritional and medication aspects of a nasogastric tube. So outcomes and evaluation of that, you really want to relieve the distension or the nausea or vomiting. Make sure proper nutrition is provided, and then, you know, if you want a lavage, make sure everything's properly washed out. And then for evaluation, you want to make sure that the patient tolerates the procedure well and that the tube is patent and properly functioning. So some potential complications of just an NG tube in general, or the insertion of an NG tube. You can possibly get esophageal perforation and a pneumothorax during procedure, but post-procedure, you really want to make sure that you are maintaining the patency of the tube, because you can get an occlusion, or you can even potentially have dislodgement if the patient wants to vomit or coughs too much. Some nursing considerations and nursing interventions for this is, before, obviously you need to ensure the reason why this is being placed by the healthcare provider, and then you need to have your 2 patient identifiers, explain any concerns, questions, really hone in on the importance of during the procedure and what they need to do to help you to insert the tube properly. Then during the procedure, like I said, you need to perform an abdominal assessment first. Always do that. And then get the aspirate, check the pH content, and then confirm placement with the x-ray. Also you need to check the nose for any like nasal deviation, septum deviation, or polyps or anything like that. After the procedure, you need to, like I said, again, sorry, maintain tube patency. Oral hygiene is a very big one, because they are not ingesting anything through their mouth, so you need to make sure it'll be really dry, and an abdominal assessment to make sure that it's still, you know, running and functioning. Some client education, explaining the procedure and what may come after that, because sometimes the NG tube isn't always long lasting. Like it can be in for up to 4 weeks is ideal. Talk the client through the procedure, like as far as tilting your head back and swallowing and doing all that to ensure that you have a swift procedure. Also, another thing that I wanted to make sure is establish a signal during the procedure if something is like distressing or something, like to raise your like hand or your finger or something, just so you know, hey, something's not right, something doesn't feel good. Some interventions that you can do are report unusual color drainage, oral care often, flush the NG tube with like 10 to 30 mils of water before and between medication administration and after, or feedings or anything like that. You want to make sure you flush it every 4 hours anyway, but it's really important to flush before medication, after medication, and if you have multiple medications, you need to flush in between each medication. You need to ensure that the suctioning equipment is functioning properly if you have to use that. And then if suction is needed, you only suction intermittently on withdrawal and never on insertion. So that's it for the nasogastric tube. I'm going to move to nursing management for enteral nutrition complications. The first one I'm going to talk about is aspiration. So I think the most important is to elevate the head of the bed 30 to 45 degrees. And then after feeding, because enteral is like through any type of tube, like a nasogastric tube, a PEG tube, anything like that. So you definitely need to elevate the head of the bed 30 to 45 degrees and then wait 30 to 60 minutes after the feeding to ensure that it is properly being digested. After that, you need to always make sure that you check tube positioning, and if vomiting occurs, you need to withhold the feeding. Another complication is diarrhea. You never want to dilute the formula with water. That comes pre-mixed by pharmacy, and so they know what needs to be in it. You don't need to dilute it in any way. Always watch for contamination. Throw out your bags after 24 hours. Make sure that the tubing has been changed whenever it needs to per hospital protocol. And then if diarrhea does occur, then slow down the formula because that could also be an issue. Maintenance of tube patency, like I've said, irrigate the water before, after, in between, whatever, just irrigate your tube because that's always the best. And 30 to 60 milliliters, kind of depending on where your tube is placed. Also, continuous feedings need to be administered on a feeding pump with an occlusion alarm. That way you know if like something's blocked, it'll alert you like, hey, okay, something's going on. The maintenance of tube placement. The two best things to do is check the tube positioning often by the marker placed upon the insertion. So like I said earlier, if the marker is dislodged at all, or if you don't see the marker, it may have moved down. So you definitely need to either check the aspirate or get another x-ray because that's the best way to see how the tube is placed. And then check residuals every 4 to 6 hours. That's one of the good things to do. Administration of medication. I've said this a lot. Irrigate the water before and after administration. More than one medication is given. Flush in between. Crushing the medications and giving it with normal saline if possible. But you never crush enteric-coated medications or long-acting. Sorry about that. I had to let my dog out. Anyway, I'm going to finish on parenteral nutrition and how to prevent other complications for that. So first of all, for infection, you must have a filter. Parenteral is anything to do with like your veins, like you're giving nutrition through your veins. So a central line, a PICC line, peripheral lines aren't preferred, but if you have to, you have to. But anyway, you have to have a filter. So also with lipids, you have to change the bag, tubing, and filter every 24 hours. And if you're giving amino acids and dextrose, you have to change the bag and filter every 24 hours and the tubing every 72 hours. You're also going to use a sterile procedure when changing central line dressings. So like if you have a PICC line or a central line, you have to make sure that you change that sterilely. So like gloves, mask, whole shebang. Then you're going to monitor for signs and symptoms of infection and monitor vital signs every 4 to 8 hours for, you know, spike in temperature, anything like that. Next, to monitor hyperglycemia, you need to check the daily labs prior to new bag administration, and then check the blood glucose every 4 to 6 hours. Really, for parenteral, you want to make sure that the blood glucose is maintained between 140 and 180. That's a little more elevated than normal, but you are giving them a lot of sugary stuff in their food, or in their nutrition. Then also monitor for signs and symptoms. For hypoglycemia, the best thing to do, monitor for signs and symptoms, check your blood glucose, but important is to keep 10% dextrose in water at bedside in case the feeding solution runs out and pharmacy hasn't sent up the new bag. You just want to make sure that you'll have that at all times to prevent them to go the other way and get hypoglycemic. For patient safety, you want to make sure that fat emulsions are infused separately and delivered at 12 hours. You also always want to compare the MAR and what you have on hand. That is #1 rule. And it never hurts to have a second RN to come in and confirm, like, hey, okay, yes, that is right, that is correct, you're good to go. Also, look over the tubing from bag. Check the solution for any leaks or color changes. That's also a good thing to do for, like, clarity and fat emulsions if they were to break off. Discontinue and replace the bag even if it is not completely finished after 24 hours. That just prevents infection and other things like that. Lastly, I'm going to talk about maintaining pee in solutions. So you always want to follow aseptic technique to reduce infection. You want to always use a filter because it just helps, you know, filter out all the stuff and make sure that no fat emulsions are like going to get clumped up and sent into the line, because that would not be good. That would just cause occlusion of your vein or artery. Then you want to label and date and time. Also the multi-lumen, so like a central line, they can have 2 or 3 different like individual lines. You always want to label one for blood, for the nutrition, because you never want to get the 2 mixed up, and you never want to pull blood or get a blood draw from the nutritional line. Obviously, you need to set an alarm for obstruction, and you also need to check infusion settings periodically to maintain correct infusion. Just that way, you know everything's running smoothly. And so, yeah, that's all I have.